How's it going, everyone? Before here, welcome to Heliopolis Radio. Today, we've been fortunate to be joined by Dr. Tranise Goodlow. She's a nurse practitioner with extensive experience and knowledge in cardiovascular health. She's been kind enough to give us her time just to share a bit about what she does and also enlighten us more in regards to cardiovascular health and as to what other programs she offers outside of that. So, without further ado, Dr. Goodlow, tell us about yourself. Why nursing, first and foremost, and what has that journey been like for you?
Well, first off, Mufaro, thank you so much for having me. I'm honored to be here. I'm humbled to be here, and I really appreciate your time as well as your listeners' time. Wow, you're challenging my memory now. It's been so long. I was a young pup back in those days. Really chose nursing. It was basically on my mother's advice. And I was always interested in helping people and always interested in learning more about the human body and how to merge that. So nursing was really a good fit. Um, my nursing journey has been interesting. I'll say that. I started out as a regular floor nurse doing telemetry, did that for about a four year period. But I will admit I wasn't very fulfilled. I wasn't very happy. So I thought to myself, what can I do next? Opted to go back to school and get my doctorate in nursing. So I finished that in 2017. And when I got my doctorate, I did my doctoral dissertation in hypertension management, particularly in the African American population. And then I also got a specialty as an adult gerontology acute care nurse practitioner. So that was back in 2017, started working as a provider in 2018, and just did cardiology and absolutely fell in love with it. Heart failure, hypertension, hyperlipidemia, coronary disease, just really, really enjoyed it. I will say last year I did a pivot in my career. And actually, I forgot to mention this. I also was a professor for 2 years
Oh,
in the
That's uh,
midst of that.
that's
Um,
that's
so
that's a lot
yeah,
of
my
academia. I have to admit, it's quite intimidating. I'm not particularly academic, so just hearing that extensive time and effort that you've put into it is truly incredible. And
well,
yeah, no, go ahead. Sorry.
I mean, it was worth it. I will say I have, and I'm very transparent about this. I've had a love-hate well, I should say a like-hate relationship with nursing. There were times I thought I would leave the field, and being a provider, it rejuvenated me. But then, you know, I was kind of lost a little bit in my career. I'm not ashamed to admit that. I enjoyed teaching, but it seemed like I wasn't getting the response I wanted from staff, like the support. I saw that our students needed to have an EKG course. I had a 3 hour electrophysiology course in my grad school, and it was great.
Mhm.
I was willing to head up the class. They ignored me. The dean didn't return my calls, my texts, emails, none of that. So I said, well, I'm just going to start my own course. So that's how Dr. G, the MP, was birthed back in 2021, and me teaching cardiology concepts, EKGs, and whatnot. But then as I was still working as a provider, again, I was just feeling not completely fulfilled. And
Mhm.
so last year, I actually left clinical practice, and I now work for a big pharmaceutical company as something called a medical science liaison. So that is basically the scientific expert in whatever therapeutic area they want you to be in. So for me, it's cardiovascular within the anticoagulation
Mhm.
arena. So.
Wow. Wow. That's a lot. That's a lot of different things. Especially with someone outside of the field who doesn't have an absolute clue about what's going on. But I was gonna ask, why is cardiovascular health important from your perspective? Is cardiovascular health a big issue in your country? And what are some of the main contributing factors, um, particularly to people's cardio health issues within the US, I would presume?
I'll go back to when I was a brand new nurse. I was enamored with the telemetry slash EKG strips. I just thought they were so elusive, and I wanted to, it's like, learning a new language. I found
Mm,
that attractive. And then, at least in America, heart disease is the number one killer here. And, the Western diet, the obesity epidemic, the lack of exercise, like, so this is kind of spiraling, right? Hypertension is a silent killer over here. So,
mm,
a lot of it has to do with educating patients and lifestyle. But as a provider, you have to be abreast of that as well, so you can have that message and connect it with the patient so that they understand that what's going on It's very important to me to walk them through the journey and hold their hand. And also
Mm,
understanding that, again, I'll reference America, the average reading level, unfortunately, is fourth grade. So
mm,
walking in there like a big hurricane, throwing around these big medical terms is
mm,
not going to get you any great patient results. You have to meet them where they are. You have to take your time and you have to show that you care because if you don't, it's really a life or death type of
mm.
scenario.
I see. Wow. And so I was just gonna maybe ask the cardiovascular system in relation to the whole body as a whole. Again, I believe in a holistic health sense, everything is somewhat interconnected. And so I don't know, maybe if I'm right again, I'm completely literate when it comes to this stuff. So I just have the questions and I'm hoping maybe they'll make sense and they'll be answerable for the most part. But is there a link between cardiovascular health and thyroid health as well? Just in terms of metabolism, energy, and body regulation, the thyroid is typically associated with that thing. I just wanted to ask, perhaps from your perspective, or from your knowledge for that matter of fact, is there any link between the two, any correlation between cardiovascular health issues and people with hypothyroidism or hyperthyroidism, things like that?
Um, the short answer to that would be yes, but it wouldn't be considered what we call like a huge differential diagnosis, meaning if someone came in with a complaint of something,
Hmm.
that usually isn't one of the top like two or three or four things that you normally think of. But I'll briefly touch on hyperthyroidism and hypothyroidism. With hypothyroidism, you worry about the heart in the sense of with heart failure.
Hmm.
Okay, because I always like to explain it to my patients. Your thyroid is your body's natural speed, right? It's your natural get up and go. It's
Hmm.
your pep. So if you're hypothyroid, you don't have enough pep. So
Hmm.
that what that means is everything slows down. And so what you don't want slowing down is the ability of the strength of the heart to pump.
Hmm.
Because the heart is a pump. So blood's either going forward or it's going backwards, right?
Hmm.
So if it's going too slow, blood's backing up, and that could contribute to heart failure, which is awful. The 5-year mortality rate for heart failure, if we do nothing, if we do absolutely nothing in
Hmm.
America, it's 5 years. And that's the equivalent mortality rate of lung cancer. So, heart failure really is a big deal. And yes, there's precursors to that. You just don't unless someone just has acute heart failure, but generally they go down this road. So
Hmm.
usually you're not just boom, they.
Hmm.
Um, as far as hyper, because I go back again to the example of your body's natural speed. Well, if things are sped up too fast, that could be a problem. You could have baseline tachycardia, which is
Hmm.
a fancy word for saying a fast heart rate. Hyperthyroidism, you could also have palpitations, right? If the heart's beating that fast, you can feel that uneasiness. Hyperthyroidism, just like hypothyroidism, affects the whole entire body. You could potentially even have high blood pressure because again, if your speed is all amped up, you know, that's going to put more stress on the brain, the heart, the kidneys, your major organs and whatnot. So
Wow. And now I actually thank you for giving that explanation. It definitely brings a lot more clarity to it. So you'd recommend that when treating your patients, um, what have you found within your treatment protocols? I know you have shifted away from the clinical aspect of it, but what have you found in the patients that you've worked with to what's led to the most success in terms of overcoming any cardiovascular health issues and somewhat even the recovery process itself? What type of habits and protocols do people implement, and also maybe medications that they take that generally lead to a more positive prognosis?
oh wow, that is a difficult question because I
Yes.
think about I think about well, is it mainly high blood pressure, hyperlipidemia, coronary disease, heart failure, arrhythmias? I mean, there's so much that we do, but just speaking broadly, my personal approach is I am huge on lifestyle modification. I don't like medicine. I know that may sound strange and some people may not believe me, but I can assure you the patients that have been under my care know. For me, medicine is the last resort. And I'll even take it a step further from medicine. In totality, in theory, and this is outside of cardiovascular health, just being a provider.
Mm-hmm.
The healthcare system, and I believe this is true globally, okay?
Mm-hmm.
We only have two options for you: meds or some kind of surgery or procedure,
Mm-hmm.
right? Like, just broadly speaking, there's nothing else that anyone can really do outside of those two very broad things. Now, there's many things within those two things, but just again, broadly speaking, there's only two things that we can do.
Mm-hmm.
Conversely, as the patient, there are more than two things that you can do. Now, in America, unfortunately, we have a problem with laziness. Okay. And so I hit it from, I'll give you an example. Let's say I have a patient who smokes, drinks, is obese,
Mm-hmm.
doesn't exercise, and eats fast food every day.
Mm-hmm.
I'm not even going to say they have sleep apnea because that would have been six things. So I listed five things to my two things. And so your five things, they they build over time, right?
Mm-hmm.
And then you come to me when it's been, I don't know how long, and say you have high blood pressure. So my conversation is, okay, we can fix this. What can you do? Because, ultimately, I would like you to stop smoking. I would like you to have moderate alcohol consumption. I would like you to lose weight. I would like you to markedly, I'm not gonna say don't eat fast food, but markedly reduce it, right? And I'd like you to be on some sort of exercise program.
Mm-hmm.
But again, I understand with me, I don't want you to do all that at once because the likelihood of failure is very high. So I ask my patients, what would be the easiest thing for you to start with? Somebody might say the food. One other person may say the smoking, whatever. I like to put the control back into the patient's hands because they're more likely to be compliant if they're picking it and I'm just explaining the journey, the process. Now, having said that, if you force my hand, right, and you're going to say, I refuse, and no, I'm just not going to, okay, then I'm forced to go ahead and implement medications. And unfortunately, if medications either don't work, and remember, there's side effects.
Mm-hmm.
That's one reason why I don't like medicines. You'll come back, oh, I'm not feeling this way. Well, I tried to talk to you about doing it this way. You said no, so I'm here, and let's hope you don't end up with very bad heart failure, get arrhythmias, then you need a pacemaker. I mean, this can really spiral. So
Mm-hmm.
just trying to meet people where they are and kind of hold their hand. And you have to force me. Now, you asked a question about what medicines.
Mm-hmm.
As far as the current clinical practice guidelines, the first thing I would generally put somebody on is a thiazide diuretic because that's guideline directed therapy. Within African Americans, then I would usually next go to a calcium channel blocker. And a non-African American, I would usually move to usually a ARB. There's angiotensin receptor blockers, and there's ACE inhibitors. I usually prefer ARBs to ACEs because ARBs usually have less side effects.
Mm-hmm.
Plus, if you do have hypertension, you're at an increased risk for heart failure. And eventually, the guideline medicated therapy, you would be on that medicine anyway, because medicines have multiple uses, of course.
Mm-hmm.
So that's like a broad stroke of my approach, but I really try to be patient. We ask them to keep a blood pressure log, buy a machine. I make sure the
Mm-hmm.
machine's accurate. Like, you're gonna see me, you're gonna come back in every 2 to 4 weeks. It just depends on what's going on and what we got going. So just holding their hand through that journey to feel support and understand and explain.
Um, wow, it's a lot of insight, definitely now to seeing how the process works. And the last question, just on this topic, not to take up too much time, a bit controversial, but again, I just felt, for listeners' sake, just asking about, there's been reports, I don't know whether they're true or not, about, vaccines and somewhat like cardiac issues emerging. I have absolutely no clue. I'm not a conspiracy theorist at all, but I did want to ask the question, considering you're a professional. Is there somewhat any leading evidence to that being the case with vaccines affecting cardiovascular health in any way, shape, or form? Just in the nature
Um,
of the way vaccines work.
that's a very hard question for me to answer because I'm not well versed in vaccines.
Hmm.
Um, So I have to be careful what I say because
No, no, 100%. I understand.
transparent with you, I'm not very well versed in the vaccines. I will say that when the COVID vaccine came out, there was some sort of study and correlation that in some young men, it could cause inflammation in the lining of the heart. But that's not in all young men.
Hmm.
It shows a propensity in some. Um, that is the extent of my knowledge as far as vaccines
Hmm.
and cardiovascular. But I will mention this again, speaking very, very broadly. Generally, in cardiology, we want you to have vaccine. Reason why is because a lot of times you're already in a pro-inflammatory state. People don't understand that being hypertensive, that's your body's inflamed. If you're a
Hmm.
diabetic, you're inflamed. If you're in a
Hmm.
pro-inflammatory state, your immune system is already compromised, whether you acknowledge it or not. So
Hmm.
why add another etiology, COVID, for example, on top of that, when you're already compromised, the
Hmm.
outcomes aren't as good in someone who has heart failure and getting COVID versus someone who doesn't have heart failure and gets COVID. So
Hmm.
it's more of a we don't want to pile on versus, oh, you better go get all this.
Hmm.
It's it's a reason for that.
Wow. No, thank you. And coming back to just nursing, do you feel, because I read your webpage and I was actually going through it and you mentioned some interesting things, so I thought I'd add them as questions, but do you feel nurses are kind of overlooked and underappreciated and maybe even undercompensated in comparison to other fields in medicine?
Emphatically, yes. Emphatically.
Uh,
Um, a couple of things I'll mention about that. Nursing is the biggest sector of healthcare, bar none. There are more nurses than any other profession. And it's interesting to me how many times we not only don't have a seat at the table, we
mm,
don't even have a voice, and we're marginalized. Um, if all the nurses said, I'm not going to do this anymore, what would happen?
mm,
What would happen? And again, I'm not here to, I respect all professions in healthcare. And really and truly, all professions in healthcare are underpaid, just like
mm,
all professions in academia are underpaid. So I'm not saying, oh, the nurses, we're the only ones. That's not what I'm saying. The fundamental issue in America is you have business people running healthcare. So healthcare has become this business. And now you're using us, right? Excuse my terminology here,
mhm,
but the analogy fits. You're pimping us out.
mhm,
Okay. So everybody, you're like, do more, do more, do more. They make money off of us and they sit back and collect on the profits. You have CEOs making 30, 40, $50 million a year.
mm,
It's just, it's crazy. I've had patients tell me before, it's almost laughable if it wasn't so sad.
mm,
Um, they told me, you're writing this medicine because you're going to get money off of it. No, I'm not. That's called a kickback, and that's illegal. I
mm,
don't get any money for writing a prescription.
mm,
And it's really insulting because when you go into this for the right reasons, you're in it for the people.
mm,
You're trying to keep families together. That's somebody's mom, grandmother, sister, cousin, best friend. That's how I view my patients. So I have to do everything possible to make sure they live a whole and happy life. Not only that, our health is the most sacred thing we have.
mm,
So for someone to let little old me manage that, I don't take that lightly. So it's very insulting if when people come at you as, oh, you're doing it for the money. You get all of this, you get all of that. That couldn't be further from the truth. Now, on the flip side, to answer your other question about the compensation piece, um, I'm not a martyr and I want to be compensated for my skills and
mhm,
being doing this for almost 15 years. And it comes a point where you say, no, that what you're offering is no longer acceptable for me. And that's one reason why I left clinical practice because what I was being paid, for the education and my experience, it just was not matching. So
Hmm.
I chose to leave, and healthcare will continue to lose good providers because business people run it and they want
Mm.
us compassion from us, but there's no loyalty, there's no compassion for the
Mm.
providers and the staff at all.
Um, quite, in truth, that's very sad to hear, unfortunately. And how do you see an issue like of that nature being resolved? Because we see now, like I know in the European Union, at least in the United Kingdom, there's always a protest for higher pay. The conditions aren't ideal, the hours are irregular, almost unhealthy to the body as well. But where do you meet someone in the middle? Because it always seems that the business person's argument is, well, then how do we manage? How do we keep things running? And I know profit always makes people come up with excuses like that. But if you were to, what would you believe would incentivize people? Because you do need nurses, you do need people who will actually hold the well-being of their community in high regard. So it'll be sad to lose a whole workforce for whatever reasons. Each one's individual. Where do you find the meeting point is? What would you ideally want to be compensated? How would you want to be compensated? What type of systems in place would you want to protect nurses and their well-being, if I could ask?
Wow, that is a fabulous question. Um, I will start at the top. We need business people to stop running healthcare because a business person's mindset is different than a healthcare provider's mindset. Now, having said that, I'm not saying you can't be both. There are many clinicians who have their MBA, but I am very against someone who's never held someone's hand while they're dying calling the shots. That's what I'm against because you've never been there. You don't know the stressors. You don't know the environment that we're in. So get rid of those people who are just strictly business and actually get healthcare workers that have business experience. That's fine. That's fine. So that's where I would start because that's where empathy would begin and realistic expectations would
Hmm.
begin. Um, as far as the compensation piece, that is complicated. Um, I say it's complicated because different practices, different hospitals, they're set up different ways. Some providers are paid based on how many patients they see. So you can see how that can become unethical.
Mm.
Well, if I can
Very
see
quickly.
in
Yeah.
urgent care over here, I'm not even joking you, there are providers that see 70 a day, 70, 70.
Mhm.
How is that good care?
Yeah.
So I don't believe that that is the answer because we have a shortage of healthcare providers. So seeing more is not equating to better quality and better outcomes. So that's not the right answer. The answer I have, it's a little controversial. People may get a little excited about it when I say it, but I believe it.
Hmm.
In America, currently, there's 26 states, and then throughout the country, all VA systems. Nurse practitioners have full practice authority, meaning they can open their own clinics. There's no physician oversight, any of that. I would like to see nurse practitioners and even PAs for that matter as well be more of a you see them first and then you see a physician because that lightens the physician's load. And there are many things when I was working in cardiology with the great cardiologist I was with, a lot of times they would just give me the lower acuity patients. You're seeing all the heart failure people. You're going to see all the hypertension. That way it freed them up to, oh, someone had a heart attack. I have to go do a procedure. I have to go put a pacemaker in. Those are the sort of things that they need to be doing. Whereas I can manage all that other stuff. And then if it gets to the point where I've maxed out,
Hmm.
or we need more assistance, then you pass them on. I think that would be a better flow as far as burning folks out and then
Mm.
nurses are being compensated properly because we are doing the work.
Mm.
So that's what I would like to see.
And just to add on to that, just a question, I guess. Every nurse is different. Obviously, you've extended your knowledge base in cardiovascular health, probably way beyond the regular nurse would do so. Would it become a thing where if you're going to have that responsibility passed on to you, a greater amount of investment and time will have to be made to make sure that the patient, because a lot of patients, in the patient's mind, and it's not even a thing to do with your qualification and your knowledge, what you know as an individual. But when you see someone's qualification, you just assume that the highest authority is the safest authority type mindset. People think like that. How would you, let's say there's an issue now and a patient's like, well, I didn't get to see the practitioner because my issue was somewhat standardized to being given to someone just underneath the physician. Not that, the person underneath doesn't know that much, but then procedurally, I just wasn't given that opportunity to protect someone from burning out. How would you navigate that gray area? Would it be a thing that nurses would have to have a certain degree of at least maybe, I don't know how much they would have to work with the practitioner physician in sessions before they're given and handled, like handling, I don't know if I'm explaining it or wording it right, but I guess you get what I'm saying, is a certain prerequisite that has to be met by all nurses before being passed that responsibility.
Um, Again, I'll answer it broadly because there's so many individual nuances.
Hmm.
Um, to be a nurse practitioner, you have to at least have a master's degree, at least.
Hmm.
I opted to get my doctorate. So there is a difference between I will say a bachelor's prepared nurse who went to undergrad
Hmm.
versus somebody who extended their education.
Hmm.
There's a misconception out there. I think the problem is people don't acknowledge nursing, unfortunately, as a separate profession.
Hmm.
A lot of what we do is similar to what physicians do, but it's a separate profession. The reason why I mention it is because the highest education in any profession is doctor. That's it.
Hmm.
Lawyers are doctors. They have a JD degree, doctorate, juris doctorate. Anyone who achieves a doctorate degree is at the highest level of their education.
Hmm.
I opted to get that. I wanted the terminal degree because I knew it would give me more knowledge and open more doors for me.
Hmm.
So there's a public education that needs to happen. And it's very insulting when
Hmm.
a patient says, gosh, you're so good. You should have just been a physician.
Hmm.
I'm the highest that I can get in my field. So because I didn't opt, because when you go to med school, you go those 4 years, you have your doctorate. That's it. There's a bad misconception. Physicians, particularly if you're in a specialty cardiology, because that's what I've done.
Hmm.
So me having a doctorate, a cardiologist does not have more education than me. He
Hmm.
has more training than me.
Hmm.
There's a difference.
Yeah.
So when I say training, yes, they have to go to the residency and fellowship. They have to do all of those. Yes, I give credit when credit's due, but I'm talking about degree wise.
Hmm.
I have a doctorate. They have a doctorate. So that's on par.
Hmm.
So understanding who you're dealing with. Another thing I'll mention that the public doesn't really understand or know is the Institute of Medicine wrote a position paper back in 2010,
Hmm.
and I believe they still have this stance, saying that nurse practitioners have equal, if not better outcomes than physicians. And a lot of times they feel that way because we slow down and we take the time to listen.
Hmm.
So the last thing I'll mention about it is this. Ultimately, if you're having a problem, it really doesn't matter who you see. It matters about the integrity of the provider. Because
Hmm.
just like there, excuse me, just like there are poor physicians, there are poor nurse practitioners. So you can't just say, oh, he's a physician, so I'm just going to go. They have bad ones. Every profession has bad people in it.
Hmm.
So I always caution patients to be careful. Be careful when you make blanket statements about, well, I don't want to see the nurse practitioner. There have been times where patients have done that to me. There's been an emergency, and I'm the only one available. So if there's an emergency going on, are you going to refuse? You know what I mean? You have to be careful. So my message to patients is take that first encounter to do an evaluation. Do you like the way the person spoke to you? Did they explain things? Did they have a plan?
Hmm.
Because if they did, does it really matter? Does it
Hmm.
really matter? So,
No, obviously there's a lot to that, and I agree with you with a lot of it. It just requires us not having a traditional perspective and view of things, and I appreciate you shedding light, particularly with the qualification aspect of it. I think um, having equal respect for what you have achieved and acquired in terms of knowledge is a very, very important thing, and I don't think that benchmark is ever recognized. There's always, and it's not just in medicine, it's in a lot of fields where there's always just this, misbalance in appreciation for what someone does. But I know I don't want to hold you too long for time. And so in terms of contacting you, firstly, now that you've moved away from clinical practice, um, do you extend what is exactly that you're doing now that you've shifted first and foremost, and then I'll ask the next question.
Sure. So I do two things right now. My main, I guess, 9 to 5 career, I've shifted into something called a medical science liaison. So my job is to talk to providers and researchers and answer their questions and be the content expert in anticoagulation specifically. So I have a lot of meetings and I talk about a lot of research. I talk
Mm-hmm.
about guideline directed therapy and just answer their questions. And I find that in this profession, even though I'm not seeing the patients myself, like boots on the ground, but because I go talk to, I presented to 17 hospitalists on Tuesday. So those 17 hospitalists could now implement what I presented versus if it was just me, I just have my patient pocket. So
Mm-hmm.
I find that I have a bigger impact in my role currently, which is very nice. Um, the other thing I do is run my business, and it's called Dr. G, the MP. And so that is geared towards nurses and nurse practitioners. When I was working as a professor, I identified a gap in education, and that's
Mm-hmm.
with the EKG interpretation. Unfortunately, it is not standardized throughout all the education. I was fortunate to have a 3-hour electrophysiology course in my doctoral program. One reason why I picked it, I was very specific on the type of program I wanted to go to. But I want to help those that need to know urgent care, primary care, internal medicine, new grad, cardiology, nurse practitioners. I want to be able to hold their hand and guide them and get them through the minutia.
Mm-hmm.
So those are the two things that I am doing now. I'm quite busy doing both, as you can imagine. Because the medical science gig, I do travel, and
Oh,
whatnot, but I lecture, I teach through my business, and it's such an honor and privilege to do it. I absolutely love it.
I'll make sure I actually put the link in below. And that was actually what I wanted to ask, because I know with medicine now, once you move across borders, each country, each state for that matter, has their own set of guidelines, rules, and restrictions. So I was going to ask, do you work with people? I'm based in South Africa. Do you extend your teaching to people abroad, or because of differences in the educational system, this side and that side, is it only restricted to the States currently right now?
So EKGs is a universal language.
Okay. Thank you.
EKGs is something that it doesn't matter where you are. Now, I will say I do offer hypertension and hyperlipidemia courses. That is specific to America because I follow those guidelines. So I may
Mhm.
not talk about the European guideline. Well, I mentioned them briefly, but I don't really focus on the European guidelines. And I do know about the European guidelines. Matter of fact, the European guidelines are ahead of the American guidelines. That is common knowledge over here.
Mhm.
But EKG is a universal thing that, if you need help with, I would be honored and privileged to help anybody with it.
Thank you. Thank you so much. And so, last question. Any words of wisdom and advice for the audience listening in today?
Wow. From a patient perspective or a student perspective, what perspective?
To be honest, I just keep that as broad a question as possible.
Okay.
It could be the first thing that comes to mind. Maybe that you'd want a patient to perhaps listen to, or even if someone in the same situation as you, a nurse or a practitioner, that may be looking at their career and reevaluating whether it's worth it or not. I guess just having this conversation with you, I can see that's a major thing that a lot of people obviously go through. So it can be on either, or it could be for both spectrums, patient and
I'll
practitioner.
start I'll start with the patient. Um, from the patient perspective, I would say make sure that you are all in. Um, because I think there's a bad misconception that patients say, I'm having a problem. They're going to fix it. Well, sort of. For example, I'll take the exercise, the smoking, all that out of it. Let's say you come to me, you say, I'm not going to just give me a pill. And I'm like, you sure? No. So I write a prescription. I give it to you. Well, if you don't take it, the onus is really on the patient. I view myself in a clinician. I am a consultant. You
Mm-hmm.
come to me and you get what I think, based off my experience, of course, what I think we need to do. I'm a consultant. People don't always listen to consultants. I'm not a judge. I'm not the police. I can't ban you. I can't sentence you. I can't do that. But I give recommendations. You have to do the work. So you cannot get angry. Can't get angry. They told me to not eat this, or I got to maybe start exercising, and they gave me this pill, but the pill makes me feel bad. And they gave me another pill, and that pill made. Well, what do you want? What do you want? So you refuse to change. You're making my job harder, but then I'm the problem. So I think patients have to take some responsibility and be amendable and understand that you're the one who's going to do most of the work,
Mm-hmm.
not me. Um, so that, and it's a two-parter. So I tell that to patients. The other thing I would say is find a provider who cares. This is your life, this is your body, this is your family, this is your legacy, this is everything. So find someone who cares. It doesn't matter what they do. Find someone who cares, because if someone cares, they're going to fight for you. You want your provider to fight for you and not just be, oh, okay, well, we'll just see him whenever. No, let's come up with a plan. Let's do this. You want someone like that. So that would be the two pieces of advice I would give patients is the onus is really on you, and find someone who cares. Um, from the perspective of someone who's in healthcare, particularly a nurse, someone maybe wanting to go to nurse practitioner school, I have a couple pieces of advice. Number one, get your doctorate. You don't have to get your doctorate. Get your doctorate.
Mm-hmm.
I would not have my job today if I did not have my doctorate. You always want to get the terminal degree. It opens doors for you that you never thought.
Mm-hmm.
Because just because you think something today doesn't mean your thoughts can't shift or change. So I would say get your doctorate. The other thing I would say is be patient with your process. Get comfortable with being uncomfortable. The most dangerous provider is the one who thinks they know everything.
Mm-hmm.
You have to keep learning. There's been times I've been in rooms with patients and I say, you know what? I really don't know. But you know what? I'm going to find out. And that's when you lean on colleagues and say, you know, I have this strange case, because every case isn't just cut and dry, you know? And I got that from one of my physician mentors. He had complicated cases. He's getting on the phone with other cardiologists. Hey, I got this in the office today. Really not sure what this is. You don't need to know everything. That's not what this is about. This is about being ethical and helping and getting the answers by any means necessary, because someone will know. You just need to find out who that person is.
Incredible. Wow. Potent words of wisdom, Dr. Goodlow. You know, there's always something amazing. And I know this, not to single out any other field, because I think the amount of love, passion, and dedication you have makes you quite phenomenal in what you do, regardless of your field. But I think with nursing, there's a great deal of compassion that you really honestly have to have, a certain integrity that exists that I don't think you get in a lot. I mean, you can get away in a lot of fields without it, but this, the way you're describing it and the pressures and everything that you've had to face, I truly have respect and admiration for just how you've chosen to bring a certain integrity and authenticity to what you do. It's really, really, from my understanding of nursing, I mean, I was in Canada for a few years. I would just be like, man, these guys suffer a lot. It's a lot. That's all. I'll be real with you. I'm like this. I was like, I met a few nurses, and I just like, man, this is hell. This is this is hell.
I well, I will I'll give you some comments on that. Yes, I agree. Back when I was a floor nurse, before I went to grad school, I was a nurse for 4 years, and I was thinking about leaving the profession. Nursing is very, very hard. And I got treated very, very poorly. Another thing I'll mention, at least in America, for the last, I'm losing track, but it's a good thing. Since 9/11, because 9/11 happened in 2001, I
Yes.
believe since 2002, and we just got it again this year. Nursing was rated the most trusted profession in America for over 20 years. So we are ethical, we are compassionate, we do care. So that's why it hurts me sometimes when I see patients and administrative disrespect our profession or just be rude or unkind.
Mm,
We're there holding your hand the whole time.
mm,
So if an emergency happened, who's the first person that's in your room? There's been many a time I was the first one starting CPR on a code,
mm,
starting chest compressions, you know? So just be kind to everyone. We are not, you're not better than someone. Well, no one's better than anybody. But I find, at least in America, and I'm not sure how it is in South Africa, oh, you're that. Oh, he's a lawyer. Oh, he's an engineer. It doesn't matter. What type of person are you? Because your profession doesn't matter. It's about your morals and your ethics and how you treat people, because that will come back to you. You
mm,
can't treat people badly. I mean, you can, but you'll have consequences. I'm just very strong on that. It doesn't matter what you do. It matters how you are. How are you?
mm,
Because my profession really doesn't matter. If I want to be good, I'll be good in anything,
mm.
right? If I want to be a good person, I'll be a good person. So I just don't like the whole stigma. Oh, you've done this. Yeah, that's cool and all, but what about you? I want to know about you. And that's what patients should be more concerned about. Are you good? Not what you do. Are you good? Are you going to save me? Are you paying attention? Do you have morals? Do you have ethics? Those are the things you need to be concerned about when you see anyone. And if the answer is yes, doesn't matter their profession. It does not matter.
Now, wow, again, powerful stuff. And I know we're concluding now. I just had one, sorry, there was one question I forgot, and this one I feel
Oh,
is actually
sure,
very
sure.
important. Because my late mother was actually a GP as well. One thing that I really, and I looking back at it, I kind of feel bad because I didn't understand. I guess you just don't understand what people go behind the scenes. You witness the bridge between life and death in your craft. You see the real deal. For most of us on the outside, it's traumatizing. It's a very, very, it's a very gray area. How do you recommend people in the field, more importantly, how important is it for people in your field to maintain their mental health, to mitigate things like depression and alienation from society? Like war veterans, they go to war, they witness certain things, they can amalgamate in society. I feel people in your field meet it's equally as same as the same as that. So, um, how important is it from your perspective that you find some ways to maintain, preserve, and look after your mental health, as well as the nature of your heart, like you said, to preserve the goodness in you, being mistreated, sometimes also being disheartened by some of the things you witness and experience. I don't know if you'd just like to elaborate on that. Was actually one of the big ones I wanted to ask. I just slipped my mind. Sorry.
No, no, you're fine. Like I said, I'm honored and humbled to be here, and I'm on your time. So, um, first of all, condolences on your mother.
No, thank you. Thank you. We appreciate it.
That's first and foremost. And thank you to her service, because it was likely underappreciated. Um, so I very early on realized that I was not going to be able to be in high pressure situations.
Mm,
I did outpatient cardiology, so what would happen with me is I build these relationships over the years, and then something happens, and I get that call.
mm,
When I was working in the hospital, yes, several times I was there holding the hands, coding, running crazy, and unfortunately, people passed away.
mm,
Um, I actually, when I first was in nursing school, thought I wanted to do pediatrics, but I quickly realized I wasn't built for that because I was holding babies 4 days old with tetralogy of Fallot. I was dealing with children with liver cancer at 3 years old,
mm,
ventricular shunts in their brain for hydrocephalus because they have water on the brain, 2-year-old child. So
mm,
I very quickly realized that kind of terminal stuff, I didn't do very well with. So I
mm,
would go home after class with a very heavy heart
mm,
and be crying. And like, why, like these children, they're just children.
mm,
And I still think about those children.
mm,
Um, so I knew back in school I was going to have to pivot because, like I said, nobody couldn't tell me I wasn't doing pediatrics. But I said no. As far as dealing with it, I think it's helpful to surround your people with your fellow healthcare workers because they've been through it.
mm,
So talking through it with peers and whatnot. Um, Also going to counseling. I'm very pro counseling.
mhm,
Um, as I kind of got older in my nursing career, I was in the ICU for a little bit, did a couple rotations in the ICU,
mm,
and it really affected me having to do postmortem care,
mm,
putting people in body bags, um, being with families, being there when they find out their loved one is no longer with us. Um, it shifts you. I wouldn't say it hardened me. I think it actually had the opposite effect. It makes me realize how precious life is and that's why I get frustrated when I see people being ugly and just people just acting crazy when you
mm,
could choose to be kind. You don't know what people are going through.
mm,
Um, Furthermore, I'll mention that I'm a Christian
mhm,
and I believe in God and I
mm,
believe in the principles of doing the Lord's work and Jesus's teachings.
mhm,
And he would not want us to be at each other's throats.
mm,
He would want us to be showing compassion through people's worst moments.
mm,
So I try to do that. Am I perfect? Absolutely not.
mm,
None of us are. But my effort is there.
mm,
So going through the ICU, like I said, putting people in body bags, that really affected me. Staying up at night, could I have done something different? What did I do wrong? Should I have done this? Should I have done that? And just replaying scenarios in your mind over and over and over and over again. Ultimately realizing that you've done everything that you could. You did do the right thing. Sometimes if it's someone's time, it's someone's time. But for me, I'm very physical. I like to exercise. I like music that calms me. So doing those sort of things, like I said, talking to peers about it,
mm,
especially if they're like on the floor, right? Like they were
mm,
with me
mm,
when this all happened.
mm,
And then ultimately going to counseling and working through those issues and continue to be prayerful and thanking the Lord for putting me in a position to at least try to help, to try to lessen the blow,
mm,
just be there to support people. So that's what I would say as far as the mental health issues that we all deal with. And thank you for the question because that's a question I usually don't get, but
mm,
it's a very important question that we acknowledge that stress
mm,
that happens when we lose people.
mm,
Obviously, a loss of a patient is different than a loss of a family member. I'm not
mm,
saying my loss is as big as the family,
mm,
but you feel it.
mm,
You feel it. I've shed many tears. I've given many hugs. I've stayed late. I've done it hurts.
mm,
It just it hurts, especially the ones when I was seeing them in clinic. Because in the hospital, it's like you see them, you care for them over a 3 or 4 day period. And yes, them passing away is super unfortunate. It sucks having to go through that, but it's worse when I know you for years.
mm,
Oh, that's Mr. So and so. He likes to
mm,
bring the cookies every
mm.
Valentine's Day, and oh, I know his daughter, and and he
Yeah,
had a new grandchild. Like when you
mm,
have that type of relationship, it
understandable.
feels, yeah.
No,
So I would write condolences cards, send them to the families and whatnot. Um, but yeah, it's yeah, it's rough.
no. Very tough stuff to talk about without being emotional, obviously, particularly when you understand death and its nature and how it's very life-shattering. Um, it's a very, very ugly thing to witness. But what I've found, fortunately, at least from my understanding, is it brings the beauty in it is how I always say how the stars align, how moments bring people together in ways that you couldn't even imagine, and it takes a certain amount of time in retrospect, I don't know if maybe it's true in your situation, but because you were there supporting a family in their moment of suffering, you're a friend, a life, you're a family member by extension. I think you could say that's God's mysterious workings in these situations, never seen in the moment. Take some time, obviously, but then you see how everything's connected in moments of adversity. So thank you for being extremely raw and real with that. It's not an easy question. I didn't want to ask it, but I felt that it wouldn't do justice to what you guys go through. Um, so thank you so much, Dr. Goodlow, for coming on and being very, very, very honest and true. It takes a lot of conviction and a lot of just passion for what you do to defend it and to protect its sanctity the way you do. So wishing you the best in your new ventures. I think, like you mentioned, now that you're doing consulting, you'll be able to extend more influence on how you think things should happen procedurally. And it looks like it's something that you're actually really enjoying doing right now. So I'm really happy. And also you have your business of teaching now as well. Again, I have a relatively small audience, but it would be great if someone reaches out to you from this side in South Africa just to gain whatever they can from one of the courses that you're teaching. So I hope ultimately this podcast, it does reach viewers and listeners there that are, interested in this field, interested in what goes on, because the world's going to need genuine nurse practitioners moving forward and people of heart and strong minds. So thank you so much, Dr. Goodlow. Thank you. It'll be great to have you go on again at some point in time, God knows when, but if the opportunity again comes, it'll be great.
Well, I have two final comments. One, regarding my teaching services, I do want to say I'm offering your listeners a 40% discount off of my entry-level course called Anatomy of an EKG. So I'll give you that information in the show notes, but the coupon code will be POD40, POD 40. So I'll go ahead and give you that information with the link and whatnot. I would be remiss, and it just doesn't feel right without thanking you again. Thank you for your time. Thank you for your platform. Thank you for your willingness to have me on. Thank you for your messaging. Thank you for being authentic and real. I am humbled to be here. Like I said, thank you. I have the utmost respect. Thank you so much.
No, again, the platform exists for people. I always tell it, it's for you to share your story, what you do, and why people, not even why people, but for people to really benefit from it. I've learned so much just from having this conversation with you. I can't even explain it, but no, thank you so much, Dr. Goodlow.
Thank you. I appreciate you.